been here this evening and attending the Clinical London Masterclass in Cataract Surgery or Complications of Cataract Surgery. I'm Jane Olver. I'm the Medical Director of Clinica, and I'm also an ophthalmic surgeon. But the is going to be Julian Robbins. He's a consultant ophthalmic surgeon who is a specialist in cataract and vitreoretinal surgery. He's also a specialist in medical retina. He's a consultant in Milton Keynes and at Clinical London. He completed his ophthalmic training at fellowship level at St. Thomas's Hospital, doing both surgical and medical retina there. And he's presented his work on vitreoretinal surgery or complications of cataract surgery, both nationally and internationally. But more about Julian himself. He's a very keen teacher and he is immensely calm. He's a good communicator and he has wonderful surgical hands. I think you have to be calm if you're a vitreoretinal surgery. I was chatting to him earlier today and I realized I could not do his work. So if you drop a nucleus into the vitreous, to me, that's panic. But no, to Julian, just calmly get on and deal with it. So I hope you will enjoy his lecture tonight. Samar is here to help me with the IT. And Julian, you go ahead and share your screen. We want to hear your lecture.
Perfect. Thank you very much. I think that was a very kind introduction.
It's true, all of it.
Some of it, at least some of it. So I think that we'll share the screen. Perfect. So yeah, my name is Julian Robbins. Welcome to this webinar, a masterclass in the complications of cataract surgery. We'll start off by going through the top topics covered today. So looking at how to identify patients at risk of potentially complicated cataract surgery, the signs to look for when detecting early postoperative endophthalmitis, implant-related problems with cataract surgery, the causes and treatment of post-cataract blurred vision, and how to recognize urgent vitreoretinal complications as well as late complications after cataract surgery. So cataract surgery is the only effective treatment for cataracts. It's the most commonly performed surgery in the UK, if not the world. We're up to around 400,000 per year in the UK alone. And good news is that complication rates are low. We're good at cataracts. We've been doing them for a long time. And it's rare to have complications, but they do still occur. And they occur for everybody at a repeatable rate. When I talk about cataract surgery, I'm really talking about phaco emulsification. So dissolving the lens with an ultrasound, as opposed to the more traditional methods, such as ECI or extracapsular cataract extraction, or ICI, intracapsular cataract extraction, where instead of dissolving the lens comes out whole. The techniques have moved on. In terms of the phaco emulsification, then, yeah, and basically in cataract surgery, we make a small incision into the eye. These days we're down to around 2.2 millimeters. The ultrasound is placed inside and dissolve the lens into fragments, which are gradually removed over the course of a few minutes. We leave behind the capsular bag, so there's space to put the intraocular lens, the artificial lens, inside the eye. And the wound is closed, usually with no sutures at all. And we're talking a 15 minutes to 20 minutes operation on the standard. So in terms of the ultrasound, then the probe is pen-shaped. It uses its ultrasound power to dissolve the cataract in two different ways. One is a jackhammer as it moves back and forth at a very high frequency. There's also that movement inside the eye creates these low and high pressure cavitation bubbles, which also help to dissolve the cataract material. When we're talking about cataract patients at risk of complicated surgery, then there's a few things that come to mind. I like to divide them up into patient factors, so patients that perhaps can't lie flat for their surgery or have a tremor, patients that have dementia and anxiety, and it means that they'll find it difficult to remain still during the surgery. Also, with cataracts, you imagine us crowd around an eye on a table with a microscope hovering above. So implications things like very small eyes or very deep set eyes have implications for us as well. Most of the cataract surgeries we do is around local anesthetic, around 95%. And perhaps some of these reasons here would be a reason to offer a general anesthetic instead. So in terms of coexisting morbidities, then diabetes may mean that cataract surgery may be complicated by macular edema. Afterwards, you have to be very careful with patients with diabetic retinopathy who have proliferative disease. They can develop neovascularization of the iris postoperatively. In terms of patients that have treatment for their prostate, can lead to a very poorly dilating pupil, making it more difficult to access the cataract and perform the surgery. There is something called floppy iris syndrome or intraoperative floppy iris syndrome, IFIS, related to alpha blockers. Other things in very obese patients, often they have very difficulty lying flat for a start. It's not normal for them to ever lay flat at night time. Perhaps they have many pillows, but also becomes necessary sometimes to operate with patients who have their full CPAP mask on, positive pressure ventilation. So there's eye factors as well. Density of the cataract plays a role as well, really. So on the top there, the little brown circle is a very tough cataract that probably wouldn't have been dissolved by the phaco emulsifications. That's a cataract that I took out through an extra capsular technique, and it's actually a very small, hard, round, brown dot. Other cataracts then, so white cataracts can cause problems because they tend to have tension around the lens. So when opening them up, they want to open themselves out, and the capsule wants to break free. Other times of odd-shaped cataracts, like in the middle of the screen there, could be related to trauma, so we're worried about damage to the zonules. In the bottom left, we've got osteosynechiae, so patients that have had inflammation or perhaps an injury before. Again, extra time is needed for the surgery and the risks are slightly higher. So in terms of predicting the risk of complicated cataract surgery, there's quite a few scoring systems that are used. Most hospitals use some form to both to sort of think about their overall risk of complicated surgery, but also in the training centre to decide on what cases are suitable for more junior surgeons. They usually allocate a scoring system to the complex factors, so the shape of the eye, the previous eye history, the eye length, some of the factors on the screen there. So there's the Mutaseb and the Habib scoring system together. Overall, you can see, if I move that on my screen so I can see it, the more factors you've got, the more risk of complication during the surgery, and this goes up, can be quite high, going up to around 16 or 17% for patients with multiple risk factors. So overall, the risk of complicated cataract surgery is low. I'd probably say usually to patients that 95% of patients don't have complicated surgery, have straightforward surgery and have better vision afterwards. The more ophthalmic conditions, and the rule for me is any ophthalmic condition that you've had in the past probably increases your likelihood of a complicated cataract surgery to some degree. Calculating the rate can be quite complex actually, so you can use those scoring systems to try and give an accurate representation of the likelihood of complications. And what's important is good preoperative assessment, identifying those factors early in order to counsel the patient and make them, give them an informed decision. So experienced cataract surgeons have more experience, and the tools, perhaps they're less than the chance of complicated surgery. Not all complications are avoidable. So I guess we'll take a break. I don't know if there's any early questions at the moment.
No, I don't see anyone. I'm very sorry, but the sound is impossible. Your speaker sounds like a Dalek. I cannot continue with the webinar. Now, I hope that's not a general comment from everybody. Can everybody else hear
as well? Yeah, I'm okay.
Oh.
I can see everything. How's everybody else? Everybody says sounds good. Mine's absolutely fine. I can hear fine. I'm okay.
Well, our apologies to the person who was finding us as a dialect or dialects. Okay, nothing else on the questions at the moment.
Perfect. Okay, I'll move on then. So we'll start off with early post cataract surgery complications. Right, so corneal edema. So most of our patients with cataract surgery, don't really see them the first day afterwards, and whenever I do, I always see some degree of corneal edema. This often resolves with time and isn't much to worry about. It's more likely to happen if the patient has a Guttata, so they have low endothelial cell count, such in the case of Fuchs endothelial dystrophy. It's much more common to be seen in longer surgery or complicated surgery, where perhaps the cataract's been more dense, or in fact there's a limited space in the eye. There's a shallow anterior chamber and a small axial length. Some patients go on to develop corneal decompensation and require corneal graft surgery, but that is rare, less than 1% chance of that. Initially, with patients that present with corneal edema postoperatively, if they're on their postoperative steroid and antibiotic combination, there's really not much to do for them. Can give extra lubricant drops if they're in discomfort. Later on, you can consider concentrated sodium chloride. And
Julian, there's a comment coming through on the questions. Tobramycin can be very toxic.
Sure, it can. So every unit that I've been to has a different regime for cataracts. Most stick to around 4 times a day, and that's a variation on Maxedex and chloramphenicol or Maxatrol with neomycin or Tobradex. I do know some centres in Surrey that are still using Tobradex. For the most part, for most patients, it's not toxic, but there are some patients that are more sensitive to it, and that's difficult to predict. There was a series of reports suggesting that you shouldn't combine Tobradex and Acular together for a set of patients who developed sort of a early corneal decompensation and required grafts. I haven't heard much of that about that recently. But you're right, and these antibiotics that we use after surgery can be toxic. Some people will be sensitive to them.
Thank you.
So corneal abrasions, sometimes the instruments during the surgery will cause a small scratch on the eye. Also, patients' eyes are anesthetized, they have a local anesthetic around the eye. And they can rub their eye, touch their eye afterwards, and not realize that it's completely numb and cause a scratch on the surface. It is very, very sore. If anyone has ever had a scratch on their eye, it's incredibly painful. And it's really quite intense for the first 24 or 48 hours, and it settles down. Again, there's probably not much to do if they're already on their drops after their cataract surgery. Adding some carbon gel or lubricant to the eye might help as well. But otherwise, just to ride it out really and explain that it'll settle down. Usually they do heal. The exception is patients that have paresthesia or poor healing of the epithelial surface. So post-operative uveitis, then most patients develop some form of inflammation after cataract surgery. For most, this is mild and settles in the period of the treatment with your steroid or antibiotic combination. There's a syndrome called toxic anterior segment syndrome, which I'll go into later on, where there's an intense inflammatory reaction just after cataract surgery. If someone comes and they're on their post-operative period within those first few weeks of treatment and they're still on drops, I think it's okay to continue with that. If they're in a lot of pain, the eye's very red, sometimes those drops can be increased to counteract it. If they've, of course, stopped, that's called that rebound uveitis or extended post-operative uveitis, then they need to be restarted on some form of steroid drops afterwards. The risk factors are, well, if they've already had inflammation in the eyes before, if they're susceptible to it, if they've had uveitis, if the surgery took longer or was complicated, particularly in the case
Julian,
of
a late question came in about the corneal abrasion, the use of bandage contact lens. Sorry to interrupt you, but I want to answer them as we go along.
Of course, yeah. So bandage contact lens in corneal abrasion then. So that's an option. And I think that patients will love you because they will feel a lot better immediately. I think that the issue that I've got over that is that it probably does put you more at risk of having an infection. So the question is, with that contact lens, how long is it going to stay in there for? What kind of antibiotics are going to use at the time? It's probably unlikely to develop, but I think leaving a lens in that puts you at risk of criticism later on should they develop an infection. So it's, yeah, so that would be my understanding of it. I think that different surgeons, different ophthalmologists probably do different things, but I think that you're taking a little bit of risk by putting one in. Okay, so yeah, so risk factors for postoperative uveitis. Then, if the iris has been manipulated, often with a small pupil, we need to use expansion devices to stretch the pupil, iris hooks to make the pupil bigger so we can operate and remove the cataract. Also means more inflammation afterwards. So in terms of edema after the cataract surgery, one thing to be aware of, if it's a small focal area for this patient here, then you need to look quite carefully across the anterior chamber, because there can be a very small fragment. When the cataract surgery is performed, we break the nucleus into very small pieces that are aspirated. They tend to fly around the eye and can get lodged, and it's not that uncommon for very, very small pieces to end up trapped either in the wound or behind the iris or in the front part of the eye, and these can be seen. Sometimes you need gonioscopy to actually find these very small pieces. If there's edema, the inflammation is persisting, if it's a piece of nuclear matter, so if it looks yellowy or browny, then probably it's best to have surgery to remove it. So wash that out and improve things overall. Very small pieces can dissolve away, but I think with this patient, if there's corneal edema, that needs a further intervention. So in terms of lens fragments, really depends on the size of them. On this picture here, this patient looks like had complicated surgery. We can tell that from there's a large wound with many sutures, likely that they are aphakic, so no lenses implanted at the time of surgery. And there's obviously difficulty here because there's many parts of the cataract and perhaps some of the soft lens matter that's in the front part of the eye. This clearly needs an intervention, isn't going to get better. Of course, these patients might already be planned to have another surgery to either have a vitrectomy to remove the nuclear fragments from the vitreous or implant a lens as well. So I've got another pause for questions.
Can I ask you a question from the audience? Is a small stitch, no, if a small stitch is seen during a follow-up post-op cataract surgery assessment a concern?
Well, again, I guess there's a bit of a variation in practice. So a small stitch often surgeons will place at the end of surgery. Usually it's either there's been a problem with the wound, it was slightly more leaky at the end of the surgery, because we don't usually put a suture in. If the surgery is complicated, then I would usually place a suture as well. It depends on what kind of material it is. So vicryl sutures are dissolvable. Not everybody uses them because they can cause a little bit of inflammation around the wound site and a bit more irritation later on as they slacken off. Most surgeons will use a nylon suture. So these tend to be black when you look at them on the slit lamp. Those ones we don't tend to worry about. The units that I worked in over the years, I do know surgeons that leave them in long term and actually don't remove them at all. They can stay there forever potentially. What tends to happen is they're not technically permanent. Over time they can erode and get weaker and spring out. But I don't think that there's something to worry about. I think that if the patient's got a follow-up appointment in a short sort of postoperative period, that's fine. If they're becoming loose, if they're irritating, then they need removed, yeah. And you have to be careful removing corneal sutures as well. So part of the suture is inside the eye, so it can be removed on slit lamp, but better that they have povidone iodine to sterilize the surface, proximeticaine or oxybuprocaine to numb it, and then remove the suture, and then give a course of sort of antibiotics afterwards. So the problem is of removing it straight out is that you can internalize the parts of the suture that are external and potentially dirty on the surface. So there's sort of rare reports of causing endophthalmitis by removing a suture post cataract surgery at any point. So not of a concern. Usually they're sort of either dissolvable and they'll go away, or that they've been left there long term. I do know actually of a surgeon that used to check their post-operative refraction and see where they were, and believe that if you left the sutures there, that they might have a better response by calculating their astigmatism afterwards. So we'd often leave sutures in the eye, multiple ones at times as well. So no more questions. I think with the chat, I wonder, I think I can only see it after you've seen it, Jane.
There's two things. There's a question and answer, and there's a chat. So every so often I go down to the question and answers and bring up something there.
Oh, I see.
So what I'll do is, as they come up, if you don't mind, I'll interrupt you.
Yes.
There's been one comment here to everyone saying sutures erode 10% PA per patient. 10% of patients, 10% of corneas.
Yeah, I mean, I agree. I think they do erode. They do tend to break, and then the patient comes back with a very sore eye. Often it's not immediately obvious. Sometimes have to lift the lid to work out what's gone on, but they know something is wrong.
I have to say it's very satisfying when you find someone with a corneal suture that's got a bit loose and maybe an end sticking out. There's such a temptation to take it out and make them comfortable. But quite right, it leads on to endophthalmitis and the risk. Yeah, absolutely. Yeah, same thing. Yeah, sterilizing it first and giving them a course of antibiotics, or Oh, PA was per annum, 10% per annum. Thank you.
Yeah. Thank you. Yeah, thanks for that. Great. So we'll talk about endothermitis then. So endothermitis is severe inflammation of the eye related to infection. Usually occurs in the early post-operative period. So my experience in the first few days, there are different organisms that present at different times, but most severe forms usually come in those first few days. They need urgent assessment, they need urgent treatment, need to come to a hospital and have a biopsy to try and identify the organism. More importantly, have an intravitreal injection of antibiotics. So the presentation, as I say, is the first few days. Usually the eye is really quite inflamed and red and painful. Typically these patients will say that initially the vision was good, but later the pain increased, the eye became more red and much more blurred. They will often have a hypopin, not always, but this pus-like collection indicating inflammation in the eye that you can see. I think that's a worrying sign. Not all hypopin, of course, is endophthalmitis, but certainly that's something of a concern and something to look for. It's around about 1 in 1,000 chance of getting endophthalmitis after cataract surgery, so I'd say pretty low. In terms of the organisms, then gram-positive organisms, so Staph aureus and Streptococcus are usually the ones in play in the first few days, and gram-negative species. Staph epidermidis is thought to occur either in the first few days or up to a few weeks later on. And when you get into weeks or months later on, we're thinking about rare organisms, Propionibacterium, or types of fungi, which are incredibly rare. So just stressing that eyes with endophthalmitis often don't look right. It's usually a hypopin. Usually there's lots of inflammation. Usually the patient is in pain. It might be quite difficult to examine them on the surface. Lots of anterior chamber activity, haze, perhaps corneal edema as well. I think it's all about history, isn't it? When they had their cataract surgery and having a high suspicion to refer and get an opinion when you see things like this. So in terms of preventing cataract surgery, prevention is definitely better than cure. It's the povidone iodine that probably makes the biggest difference. So sterilizing the eye at the site of the surgery, but also in the European study, it's the intracameral cefuroxime. So at the end of surgery, we inject antibiotics into the eye, into the front chamber, and that has a significant chance of reducing the amount of endophthalmitis postoperatively. There are units that don't use cefuroxime, although it's recommended if you have a centre that has a very low incidence. Actually, it's left up to you whether you want to use it or not. But every centre I've worked in does use it. So in terms of treatment of endophthalmitis, patients need to come to hospital, need to have an urgent vitreous biopsy and intravitreal antibiotics. Usually we use vancomycin and tazidine as a standard. Amikacin was previously used, but it's gone out of favour. In terms of the kit that's used, it's usually most good eye departments have a kit ready. It's an emergency situation. This needs to be done as soon as possible. Don't be ordering bits of kit. Often though, with the antibiotics, unless you're in a big centre, they need to be diluted. So there's a process to follow about drawing up essentially a vial that's meant for intravenous use and diluting that down to the concentration that you want and the volume that you want in the eye. We're injecting a very, very small amount, 0.1 mils of each of the antibiotics, so it needs to be carefully diluted. So yeah, it's just a matter of getting a vial, adding some saline, taking it back out and diluting it down to your 0.1 mils that you need. So in terms of procedure, it's treated like any small surgical procedure. I mean, it's much like an intravitreal injection that we do so commonly now in the eye clinics. So clean around the eye, use the povidone iodine, put a speculum and a drape around. First is to remove a small amount of liquid from the aqueous from the anterior chamber. Usually use a very small needle for that, and then mark up, and then, as if again we're doing an intravitreal injection, to draw back a bit of the vitreous to send away, and after that inject the intravitreal antibiotics. Often, unfortunately, it's an uncomfortable procedure for the patient. Their eye is already inflamed, they're already in pain. It's a good idea to use some lignocaine or some anaesthetic around it as well. Afterwards, they usually end up on a combination of steroid and antibiotics, usually cyclopentolate, so dilate the pupil, keep them more comfortable afterwards. In terms of antibiotics, that's either moxifloxacin or ciprofloxacin, which has some penetration to the eye.
Julian, before we go on to the surgical side, I'd just like to ask you, a question's come up which is very pertinent, and it's patients who have pre-existing blepharitis and meibomian gland dysfunction. How much preparation should we all be doing for those patients who are about to go in for cataract surgery, so as to hopefully reduce the amount of organisms around that might increase the risk of endophthalmitis? Yeah,
so good question. I think that it's common to patients to have blepharitis, and blepharitis is very common in the community. Patients that have glaucoma on drops have a higher rate of blepharitis also. I think that it's about educating them beforehand about lid hygiene and getting their eyes getting into a routine of cleaning around their eyes. Hopefully these things are picked up at a preoperative assessment. I think that if a patient turned up on the day of cataract surgery and they have a lot of discharge or a very red eye, then because it's often a routine operation. How many times is a cataract urgent? Very, very few times. So better to delay if things are triggered at that time. It is difficult with patients that have very chronic blepharitis, and it's difficult to get rid of that altogether, to eradicate it. They've had it for many years. They're perhaps elderly, they can't do their lid hygiene very well. Often what we do is probably use some chloramphenicol ointment for a couple of weeks preoperatively, so you know that it's sterilized beforehand for those patients. So what you don't want is them to be cancelled on the day, and then unfortunately the situation repeats itself, isn't it, the next time they come along for surgery.
Thank you.
Good. So I want to talk about say my role is as a retinal surgeon is to deal with a lot of complications that occur as a result of cataract surgery. So one of those complications, endothermitis, is a very serious one, and there's always questions, and I'm always asked this, and on the units around me that refer to me, whenever a patient develops endothermitis, will usually come to me for an opinion to see whether we should perform a vitrectomy, so clear out the vitreous gel. And it's an interesting topic of conversation, really. It really comes from the early vitrectomy study back in the 80s, which gave us the first evidence of what organisms usually cause endothermitis, and gave us some information about the actions that we should take afterwards. It really looked at the role of the vitreous tap and intravenous antibiotics, as well as vitreal antibiotics. The theoretical advantages of vitrectomy are removal of all the organisms and toxic membranes and things and opacities, and also be able to get a good sample for sending away. The problem with biopsies in the clinic or in the treatment room in the eye clinic are that often very small samples are obtained, So there is an argument to say that if you perform a vitrectomy, you get a much larger sample, much better chance of identifying an organism. But unfortunately, it's difficult to plan those things, isn't it? If you've got access immediately to theatre, then that's okay. But actually delaying that surgery by hours or even a day is probably much more detrimental than just performing it as and when you see them. So in the early vitrectomy study, everybody had a vitreous tap, so taking a sample of the front of the eye and the back of the eye, and they had amikacin, as I say, a slightly older antibiotic, and vancomycin. And patients were randomized to those that had a vitrectomy with and without intravenous antibiotics. And the other group was patients that had intravitreal antibiotics with and without intravenous antibiotics. Overall, it was thought there was no benefit to vitrectomy unless the vision was very poor, hand movements or less. If you are hand movements or less, or perception of light, you had a much higher likelihood of achieving a better visual acuity. There was no indication for systemic antibiotics with endothermitis. It did find that the vitrectomy, the vitreous tap, was more likely to be positive, probably because you were able to get a larger sample and identify the organisms that way. So there wasn't any benefit to the antibiotics. Amikacin is not widely used anymore, and we use cafetazidime. We didn't study other groups of endothermitis, so non-cataract related. We didn't also include any of the benefits of intravitreal steroid. So things have moved on. That study was in the 80s. Later on, a lot of those patients did go on to receive a vitrectomy. Often that was due to other sort of secondary developments. People tend to interpret the vitrectomy study in different ways now, and that's why there's a question as to whether these patients should have vitrectomy with their endophthalmitis. So the theory is, with more advanced disease, with more virulent pathogens, if they're not responding to antibiotics, they can have vitrectomy at the time. The surgeries that I've done for endophthalmitis tend to be very difficult. Often the eye is very inflamed. Often there's pus in the anterior chamber. The cornea is very hazy. It's difficult to get a good view at the time. So not an easy thing to do. And results tend to be mixed, unfortunately. So in more modern papers, groups are performing early vitrectomy and have had good results. And in this study, as opposed to the EVS, they found that patients achieving 6-12 vision was around 90% versus around 50% in the early vitrectomy study. There are other indications, though, for vitrectomy. To see a retinal surgeon after endophthalmitis, often these patients develop epiretinal membrane or change in the vitreous, vitreomacular traction, perhaps cystoid macular edema. Rarely can develop retinal detachment as well, and that's usually indicated with a very poor prognosis or non-clearing opacities in the vitreous. So it's quite common that afterwards, even though things settle down, the vision improves, there's still membranes and debris floating about. And this is more than the usual sort of PVD and floaters that the patients have. This is quite significant. Also, rarely in very sick eyes with severe infections can develop hypotony. Usually falls on a retinal surgeon's shoulders to drain choroidal effusions, so making incisions into the sclera and draining the fluid and trying to improve the outcome overall. So in terms of detecting, it's important to remember that not all red eyes after cataract surgery or endophthalmitis, but have a high index of suspicion, so particularly when the vision is poor, particularly when there's a hypopia, particularly when they're in quite a lot of pain. The ways to kind of differentiate then, if there's a hazy view of the vitreous, if it's very clear cornea, it's probably unlikely if there's a hypopia. And as I say, I think most patients will say initially the vision was better, but then later deteriorated. And it's that timing issue as well, isn't it? So I think if a patient is coming many weeks after surgery, although endophthalmitis is still possible, it's much more likely in those first few days of presentation, and probably not in the first 24 hours, more like those first sort of 48 to 72 hours. What can happen though for patients to get a severe reaction in the first state postoperatively can have a condition called toxic anterior segment syndrome, so TAS. So it's a sterile reaction, so it isn't related to infection, but can definitely mimic it. Often, as the picture on the left side of the screen, there's a lot of fibrin that develops in the eye, so sort of almost like a cobweb over the pupil, often around the iris, often the Saloniki as well. They're usually in pain, they're very light sensitive, the eye is usually red. I haven't seen this as often recently, and I think it's better. It's probably that over time we're getting better and better. It's thought to be related to contaminations and toxins. So in the fluids that we use, obviously these ultrasound devices are sterilized. Sometimes you can get little small fragments that are left behind that are resistant to sterilization. They release little toxins which can irritate the eye and cause this intense inflammatory reaction postoperatively. Again, it's a bit like endothermitis that their vision is very blurry, eye can be painful, can also have a hypopia sometimes as well. The good news is that most respond very well to topical steroids, even within the first hour or so of treatment and settle down. Those that are left and don't present, perhaps don't seek treatment early on, can go on to develop secondary glaucoma from all the fibrin and problems with pressure later on.
Julian, before you go on to hypopion, there's a question about a sort of lesser form of hypopion, which is, can you talk about cells in the anterior chamber post-operatively? So an optometrist is seeing a patient in their optometry shop and they see cells. Can you give some advice on that, please?
So I think it very much depends on where they are post-operatively. So if this is someone that is on treatment still, so most centers will still give 4 weeks of steroid drops. If they have cells in the anterior chamber and they're still on drops, I don't believe it's a worry. I think that is normal and can settle down. If patients have cells after their treatment is finished, then they probably warrant referral back. It is a bit of a grey area. Sometimes cells are difficult to distinguish from perhaps pigment cells that float about. Perhaps the surgery is more traumatic. They've had a device to stretch the iris, so you can get little cells that float about from that. Some patients aren't symptomatic as well, but I think it's reasonable to get an opinion about whether to treat that. The problem is that you don't know, and I find this as well, which way it's going. So if you see someone who's stopped their drops 3 days ago and they have a small amount of cells, you don't know whether that's such a small amount, it's going to be fine, it's going to settle down, or actually that's the start of a rebound uveitis. So in my opinion, I'd probably treat them, give them another course of steroid and probably tail it off over a few more weeks rather than waiting. Because if you leave it a few more days, they come back with a very red and painful eye and inflammation, iris is stuck to the intraocular lens and things like that. It's better to treat it, I think, proactively. So I guess it depends on the timing of it.
Another question, Julian. I know you've prepared some wonderful polling questions. Are you going to do them all at the end?
I was going to do that at the end because I thought that would make it more difficult.
It will be more difficult. You're quite right.
Yeah.
So we've got to be very attentive.
That's exactly. So yes, there's the poll and the quiz at the end. Everything in the quiz I've already said, or I'm going to say. Most of it is already on the slides as well. But I think from the last quiz that we did, people did very well. So I had to up my game.
So you've made it more difficult for us this time.
More difficult this time, more challenging. Okay, great. So yeah, so the questions will be at the end, and we'll go through the answers as well. So in terms of hypopion, then, so not all hypopions are the same. So this is a black and white photo, but the case of this one is blown up quite as large as I can get it without making it to low resolution. But you can see actually this is little crystals. So instead of being a sort of flat surface hypopion, it looks almost shiny, hyper reflective, almost like little crystals are in the front part of the eye. And that hypopion is actually a pseudohyphopia, so not a real hypopion for inflammation, but as a result of the use of triamcinolone. So in complicated cataract surgery, where there's been a rupture of the posterior capsule, vitreous will come into the front part of the eye. And that's a problem because it's sticky. It will stick to the pupil, it will stick to the wound and leave the wounds open and put you more at risk of endothermitis and complications related to that. So a lot of surgeons will use triamcinolone, so a steroid that sticks to the vitreous to visualize it. We're all sitting here today, unless anyone here has had a vitrectomy, but we're all seeing through our vitreous. It's completely clear. It's almost invisible, so it becomes difficult to see and tell how much you removed at the time of surgery. So a lot of surgeons will use the triamcinolone to stain the vitreous so they can see when they're removing it and performing that anterior vitrectomy. The problem is that triamcinolone, if it's not absorbed, usually either goes to the back of the eye, and then later on, when the patient's sleeping, they're rolling in the night, some of it makes its way back into the anterior chamber again. It usually causes a lot of panic because it's associated, obviously they've already had complicated surgery. Maybe their vision isn't very good because it was a longer surgery and took longer to do. But actually in this case, there's nothing to do for it. Examination slit lamp, it's usually very white, very clear, very crystalline, and hopefully you've got that sort of feeling about what it is, rather than rushing in and doing a biopsy. So it has a ground, so to speak, ground glass appearance. There's little refractile particles. So on the picture on the right, there's a little crystalline parts of the triamcinolone, and it's been reported as shifting position. So I've never done this, but if you ask your patient to lay down on the side, because there are little crystals floating about, they will settle like a snow globe in a different area. So something to think about. Usually these clear by themselves. Implant related complications then. So we dissolve the cataract, we leave behind the capsular bag, but implant an artificial lens inside. Usually that's made of acrylic and lasts forever, but they're not without problems as well. So lens malpositions and subluxations. On the picture on the right is a patient that's had their cataract surgery weeks ago. They're very happy because their vision is very good, but actually when you have a look in, that's a small haptic, it's the leg of the intraocular lens that's not quite gone in the capsular bag. And the problem with that is that although initially this patient has no inflammation whatsoever, they have 6/6 vision, they're very happy. Eventually, later on, you probably think this will cause some kind of erosion or some kind of inflammation. So difficult sells for the patient, but for me, that's the patient needs to go back to theatre and have a secondary procedure to tuck that haptic back in. Also with that, you're thinking about whether the lens is slightly tilted, whether they actually get a slightly better refraction. Also quite scary when the patient is 6/6 vision, that when you disturb it, you're not going to ruin that. Hope for the best really, but in this case, this is one of my patients that was referred to me. Actually tucking the haptic back in went very well. Vision was very good afterwards. Patient was happy. That's a very short procedure. So the causes of it, either that the lens hasn't been implanted at the time of cataract surgery, and that does happen. Often it might be related to a previous trauma. So they have damaged zonules, a weakness in the capsular bag. It's much more common if you have high myopia or a previous vitrectomy, or indeed patients that have Marfan syndrome. So other malpositions then, on the left is an optic that's captured in the pupil. In the center is a subluxation, inferior subluxation of the lens. Those fibers that you see there are the posterior capsule actually been split. So this patient has had posterior capsular rupture. It's not really clear whether that lens is in the capsular bag or in the sulcus, but either way it's dislocated and definitely needs more surgery. And again, postoperatively, often with weakness of the zonules, when we implant the lens, initially things can look very good, but later on, as the capsular bag changes, the lens can start to change position. This one is superiorly subluxed or supraluxed, and this one inferiorly. So it's a bit of a judgment call about these patients. So often you'll see very partially sublux or malpositioned lenses where the vision is good or reasonably good. And it's a risk-benefit of how much harm you're going to cause by having another surgery, a potential risk of infection, potential risk of problems with the cornea or inflammation or cystoid edema afterwards, versus leaving things as they are. as I say, I think that my tendency is if the vision is good, the patient is happy, is to leave them alone, maybe arrange a follow-up visit for them. If it's causing secondary complications like cystoid edema or inflammation, or the vision is poor, then they're not for IOL exchange. Sometimes, if you're lucky, you can reposition these lenses. So if there's been a weakness in the posterior capsule, they can be manipulated to be captured in the anterior capsule. So move them back in position and capture them. Often, a lot of them, unfortunately, need to be explanted and a new lens placed, which I'll come on to. So in terms of full IOL dislocation, then, so this is intraocular lenses that have left their position altogether. They might well be entirely in their capsular bag, or separate from that. The top picture is a ultrasound image of an intraocular lens that's fallen into the vitreous cavity, and at the bottom is a rather lovely Optos photo of an intraocular lens that's fully within their capsular bag. It's presumably dislocated sometime afterwards. The clue on that photo, by the way, is the sort of elevation around the edges. That patient has almost certainly had a scleral buccal retinal detachment surgery that likely led to weaker zonules or more complicated surgery. And looking at that opacification around the lens, this probably happened sometime later on. So yeah, complete dislocation, complete lack of zonule support, or surgery complicated by posterior capsule rupture. These patients need a vitrectomy to remove the lens. It's not actually an urgent surgery, so especially on that patient at the bottom with a lens inside the capsular bag, it's not true that it's bouncing around and hitting the retina. I think that there is more of a worry if it's a sort of a bare lens with haptic edges that could rub, particularly if it's sitting on the macula. I don't think I've ever seen a lens sitting on the macula, but in theory, if it was, then that might make it more urgent. I would slightly worry, though, that if your lens is dislocated into your vitreous, and then you're more at risk of retinal tears, isn't it? It's disturbed your vitreous cavity. It could have put tractional forces on the sort of anterior vitreous base. So for that reason, patient needs to be monitored. But exact timings of it are probably not as important as you think they are. Sorry, I would say the other reason would be if it's causing a retinal tear or retinal detachment, that would be an urgent cause for it. So other lens-related issues, uveitis, glaucoma, hyphema, or UG syndrome. So as a retinal surgeon, I do see this actually fairly commonly. So patients that come who have had that cataract surgery, sometimes many weeks, sometimes many years before, suddenly get black dots, floaters, and lose their sight. So usually they describe a swirling pattern. It happens over the course of 30 minutes, and after that, they really can't see anything at all. I think you can get different parts of this as well, so sort of crossovers. I don't think you really need to have a hyphema or uveitis, but what it comes from is intraocular lenses, often lenses that are in the sulcus, so they've not gone into the capsular bag. It usually means they've had complicated cataract surgery, and it rubs on the iris. So this is not something you can see without transilluminating. So getting your slit lamp, shining your beam through the pupil, as the bottom left picture there, will give you an idea of what's happening. So in that bottom picture, that was actually a patient who's had a one-piece intraocular lens that is actually in the sulcus. So there are lenses that are designed to go inside the ciliary sulcus to fit there better. If you're implanting single-piece lenses, they tend to move about. When you're blinking, your orbicularis is very strong. So actually your anterior chamber slightly moves and your iris slightly moves with it. So as those lenses bounce back and forth, they erode pigment. It can cause, of course, raise intraocular pressure, and glaucoma can be part of the syndrome as well. Sometimes they can have a hyphema, which of course confuses everybody as well. Why has the patient got a hyphema? They've not had any surgery for a long time. Why has this suddenly happened? Again, it's a difficult one. I think if they're going to get recurrent vitreous hemorrhage, if it's very dense, then it's clear that they need to see a retinal surgeon like myself and have a vitrectomy, perhaps put the lens in a better position. Ultimately, you need to consider whether you should remove that lens and put another lens in place. It's been reported that, I've never seen this done myself, but you can perform a laser treatment to the iris. So if you can find the offending blood vessel that's causing the bleed, you can target that. But otherwise, it's in terms of repositioning the lens, either capturing it in the
Julian, do secondary anterior chamber lenses cause UG syndrome?
anterior chamber lenses.
Because the posterior surface can rub against the iris.
Yes.
So are they just not done very often nowadays? So that's not really.
Well, I think it's probably for most surgeons still the method of choice. Actually, if you don't have any capsular support, if you can't put a lens inside the ciliary sulcus, and then anterior chambers are still used quite a lot. I don't see UG syndrome from then, or at least I've never seen one. Is it because if you've got the right size anterior chamber lens, then it's angle supported, if you like. It shouldn't really be rubbing. Can get things where lenses are put upside down and then they're bowed the wrong way and they can rub and erode. But I've not seen many. I've not seen any with an anterior chamber lens, but potentially yes.
Do the anterior chambers have any particular complications relating to being an anterior chamber lens?
They do, and I'm going to come on to that.
Oh, sorry, we're jumping the gun.
That's right. Yeah, that's good. Yeah, great. So yes, consider a lens exchange of vitrectomy again. UG syndrome, UGH syndrome, uveitis glaucoma, syndrome. So just a mention of posterior capsule rupture that I mentioned already. So it's probably the commonest. Oh, sorry, beg your pardon. This is because my little screen is just hiding my title. Let me fix that. That's better. Posterior capsule opacification and PCO. It's a variable rate. It's thought to be around 10, 20, 30% of patients develop it. Over time, it's less and less, probably because the lens design. It's thought that the square edges on the intraocular lenses have had a big difference, preventing these cells from proliferating over the posterior capsule. But this all happened. There are different types. So I'll show you some elstonic pearls and fibrous plaques or dense membranes. Here's some pictures. Oh, there we go. It's coming up slowly. So yeah, different patterns, pretty patterns on the posterior capsule surface. Often seen better again with the slit lamp beam coming straight ahead and transilluminating the capsule. So this is elstonic pearls. So variations of posterior capsule opacity can look quite pretty. Someone's ring, so more sort of intense fibrosis around the posterior capsule. And it's even quite thickened on the cross section as well. So what's the treatment for posterior capsule opacity? Well, it's YAG laser capsulotomy. So yttrium, aluminium, garnet, it's the gases inside the laser used to intensify the light. It's a safe procedure. There are small risk of complications. So inflammation is very, very uncommon, but sometimes seen. Often you get small pits on the intraocular lens. So you may well see patients in your practice where they've had a capsulotomy, posterior capsulotomy for their posterior capsular opacity, and they have small dots on the intraocular lens. They're not thought to be visually significant, as in the studies when they've looked at this. Patients with small pits don't have any problems with their visual acuity. If you have a lot of pits, there can be some complaints of glare, but one or two bits don't make a difference at all. I think I've seen one or two patients that have had a posterior capsulotomy and had a dislocated lens afterwards. It's very, very rare. Often what will happen is, again, if the surgery is complicated, perhaps the lens looks very slightly tilted, often get referred to a retinal surgeon like myself to decide on what to do. People are worried, obviously, about performing a laser that's then going to leave the patient with no lens in the right place and very poor vision. But often I tend to be a bit braver doing the laser and just being upfront with the patient, saying there is a small risk of this happening. But if we leave you with the posterior capsular opacity, you can't see, your vision is very poor, you probably can't get the glasses that you want to. So you need to do something about it. Some cases, if it's very thick, again, need to have a vitrectomy. So the YAG laser is very good in most cases, but not for all patients. I'm often hear things that YAG laser causes retinal detachment. I don't think there's ever been any evidence of that. I think the problem is that these are patients that have had cataract surgery that has increased their risk of retinal detachment. Often they are market patients as well. But as far as I'm aware, there is no evidence to say that YAG capsulotomy increases the risk of retinal detachment.
I think there's been anecdotal cases where the YAG laser, posterior capsulotomy, has cracked the lens?
Yes. Yes, so it is possible with a very high power to crack an intraocular lens. I think that will probably come down to some form of error, usually with the power that you're using to clear the posterior capsule, it's very low, but potentially, yeah.
Does the design and the age of the lens play an influence on that? Very rare occurrence.
Not that I know of, no.
Thank you.
Yeah, I think the YAG lasers can be very powerful. You up the power, have to be very careful. I think that would be not a good situation if you've cracked the intraocular lens. I like you say, I've heard of that, but never seen it. But potentially, yeah. So after you've performed a posterior capsulotomy, you should see a nice clear window. It's not actually important to get a very, very big window there. I mean, imagine most patients' pupils they aren't walking around dilated. So just clear that small window in the center. IOL pacification is something that, again, I think is less common. There was a period of certain types of intraocular lenses, certain designs that had a very high rate of being pacified. Of course, these patients come later on. Their pacification happens a year or two, or even later after surgery. And the first assumption, as per that picture, is that they have a posterior capsular opacity. So I think most commonly I've seen them when someone has attempted a YAG laser capsulotomy and failed, because it's the lens that's pacified and not the posterior capsule. Often they come with a few lens pits, and it can be quite difficult to differentiate between the two. Again, you've got to make a judgment call. Doing a big surgery, explanting the lens usually means you're going to have vitreous loss, maybe have to have a vitrectomy at the same time, put another lens inside is a big deal and a big job. So it depends on their symptoms. If it's mild, then probably leave them alone, or at least monitor them. And in cases where it's quite severe, then those lenses need to come out. Difficult judgment call. So posterior capsule rupture, then PCR, variable rates. I think most would say an acceptable sort of level for cataract surgery is probably around 1%, 1 in 100 chance. It does vary though. And I think that the part of that depends on the complexity of the cases. So if your cataract surgery population is patients with no risk factors, then you might have a better rate than someone that has patients that have more risk factors. So it is variable. Obviously, with junior eye surgeons, it tends to be a little bit higher as well. It's really that the lens, the capsule separates, isn't it? The front chamber and the back chamber of the eye. So when you're, imagine on the picture on the right, you're resolving that intraocular lens, the instruments, the ultrasound can touch the posterior capsule surface. There could actually already be a weakness in the case of posterior polar cataracts. There's a weakness in the bag, or perhaps they have vitrectomy surgery or previous intravitreal injection, which has touched the lens, makes it more likely to rupture during that manipulation during the surgery. When it happens during the surgery, you can either have vitreous coming forward if you disturb the anterior hyaloid face, or without. With vitreous loss, obviously worse. Vitreous enters the front chamber of the eye, and you need to have an anterior vitrectomy to remove some of that, to push it back to finish your surgery and put the lens inside. Overall, it's a sort of a low risk. The problem is, though, if you have a posterior capsule rupture, is you have a no position to put your lens in, the standard position inside the capsular bag. So you think about planting a lens in the ciliary sulcus just in front of the capsular bag, work quite well, or indeed the anterior chamber lenses. More modern lenses that have come about are iris fixated, which some of you may have seen, so artisan lenses, which I'll come on to as well, or scleral fixated lenses. So that's come out a little bit blurred, isn't it? So anterior chamber lenses, I'm sure you're aware of, angle supported lenses. So position in the front part of the eye. They're easy to do, they've been around for a long time. They do cause secondary complications, of course, but in terms of difficulty of surgical technique, then quite low. Most cataract surgeons are comfortable with it. Iris crawl lenses. So again, a more modern technique, often called artisan lenses. More difficult to learn and more potential problems. This is about having a very large incision and planting a very large lens. You worry about these. They can either be implanted behind, so it tends to be if you're an anterior segment surgeon, if you're a cataract surgeon, you're not a retinal surgeon, you tend to put them in the front part of the eye, as for this patient. Retinal surgeons tend to like to put them behind the iris, so clip them from the back. The reason is thought to be you get less inflammation, less chance of problems. Of course, that's more difficult to clip it from behind, more chance of the visuals coming forward. So yeah, difficulty with this technique. Of course, if you have a complication at the time of surgery, these lenses are special order and more expensive, and it's difficult to implant one at a time. Nobody has a bank of these lenses, so it's already a secondary procedure that you need to perform. Also useful to be a retinal surgeon when you're implanting scleral lenses. These are much more difficult. So let's say an anterior chamber lens, if I had to implant one on a patient from start to finish, maybe just a 20-25 minute surgery really. In terms of scleral fixated lenses, it's technically much more difficult. So in this case, they are making small incisions in the sclera. They're using the haptics, so the legs of the intraocular lens, to pull them through, so grabbing them on the top right picture, pulling them through the sclera and pulling it through the other side, and either making a little tunnel and suturing over the top of them. There is a technique called a Yamane technique, where you melt the ends of the haptics to form a bulb. That stops them from dropping back inside the eye. But definitely a very steep learning curve to these. I think they're always in some way challenging. More modern techniques, and they now have a lens called a Carnevale lens that's designed for the scleral implantation, which can work quite well. So there are problems with all these other lenses, so that undoubtedly the best position to put an intraocular lens is in the capsular bag. With anterior chamber lenses, it's fairly common to get corneal edema or touch of the cornea in some cases. Often, a lot of patients have a chronic uveitis, so a very low grade. And the question before about what to do with patients that had a very small amount of uveitis, it's a difficult one for myself as well. So if they've had an anterior chamber lens, they can have a very small amount of inflammation that you can see on the slit lamp, perhaps the odd cell. You can give courses of Maxidex and steroid drops for a while, stop them again, and usually find that it's come back again. Other options is you could give them a once a day steroid drop to continue forever, not particularly satisfactory either. If it's a very small amount, I think the tendency is to keep monitoring and keep them under the hospital service and bring them back and check their intraocular pressure and check for macular edema. Again, weigh that up versus another form of surgery. So with scleral fixated, as I mentioned, the surgery is more technically difficult. There is a chance of angle closure and around about 15% of decentration or dislocation altogether. So a chance of when you've done this surgery, you do it again later on. Particularly in case of, let's say, a young patient, this lens is going to need to last them maybe for another 30 or 40 years. With those iris core lenses or those scleral fixated lenses, those attachments can weaken, might need to be done again. So yeah, iris fixated lenses, they can erode through, they can dislocate. I've seen some that are loose inside the anterior chamber, of course, and damage to the iris stroma, and again can cause this low-grade inflammation or swelling, cystoid edema at the back of it. So is there any more questions at the moment? We're going to move on to sort of retinal complications.
We probably have to move on fairly promptly, because I said it was going to be an hour. If the audience are happy, we can go on for another 15 minutes to 20 minutes.
Yes, sure. I should speed up.
But let's find out what the audience think. Can we have some response from our attendees, please? Because we want to do the quiz. There's some really good questions. We want to know whether we've listened. And surprisingly enough, very few people have left. So they're all still there. Sure. Yes, it's fine, okay. Couple can't stay, happy to carry on. He's brilliant, keep going. There we are. Keep going, Julian.
Thank you. Yeah. So yeah, well, I'll go a little bit faster, shall I? So post-cataract retinal complications, cystoid macular edema, often called Irving gas syndrome. So swelling of the retina as per the OCT at the bottom. Usually happens around 6 to 10 weeks after cataract surgery. Patients initially have good vision and they're happy, and again notice either blurred vision or distorted vision. When you look in, examine the slit lamp, there's loss of the foveal reflex, can look a bit thickened if you're looking both eyes, see that the retina is thickened there, and can follow any intraocular surgery, but definitely more likely if the surgery has been complicated, took longer, or if there's vitreous loss. Again, patients with diabetic retinopathy or maculopathy are much more at risk of it if they've had a previous retinal vein occlusion, previous uveitis, or epiretinal membrane can increase the likelihood to treatment. If we're talking about one very small bubble, one very small cyst of intraocular fluid, then it can be left at home alone and monitored, actually, particularly if they're asymptomatic. But if they have reduced vision, if they had blurred vision or distorted vision, I would treat that with a further course of Maxidex and Aquilar non-steroidal anti-inflammatories. Often, unfortunately, for some patients, it's refractile, so it doesn't respond very well, doesn't clear with drops. And everyone does it very slightly differently, but I would proceed on to an orbital floor or a subtenons injection of steroid around the eye, and later an intravitreal implant. So drop nucleus, so complication of cataract surgery that again comes to myself. If you have a posterior capsule rupture and pieces of the cataract end up in the vitreous, if it's very small amounts of soft lens matter, it can dissolve, can get better. Usually the patients are very symptomatic of floaters, that happens. But any nuclear fragments usually need to have a surgery unless they're very, very small. It's probably around 1 in 300.3% chance of this happening during cataract surgery. Need to see someone like myself, have a vitrectomy. We call it a fragmentome, which is basically another type of ultrasound that dissolves the lens from the back of the eye and implant the lens at the same time, ideally. So quite a dramatic picture of a retinal detachment after a cataract surgery. Again, I would say it's surgery that's taken longer to do, has been more complicated. Vitreous coming forward, that's put traction, that's created tears and holes. So interestingly, I do make patients aware of this, particularly myopic patients preoperatively. If you are short-sighted, if you have a complicated surgery, if you're young, if you haven't had a PVD, your chance of retinal detachment after cataract surgery is significantly higher. So in the whole population, it's probably 2 or 3 times higher. If you are a very high myope and you're young, perhaps you've had an early lens exchange surgery, so a cataract surgery before it's a cataract, you are definitely more at risk of a retinal detachment. There's also, oddly, and this is statistically significant, a male predominance to it as well. So around about 65–70% chance. And of course, yeah, those without a posterior vitreous detachment. So retinal detachment, your retina separates the back of the eye. Usually patients will complain of flashing lights and floaters or shadow, and they need to have a vitrectomy with the gas bubble, cryotherapy, or laser to treat those tears and then fix it. Late complications then, capsular phimosis you may have seen. If it's not too bad, they don't need any treatment. If it's quite severe, they can have a YAG laser to the anterior capsule. That is much more tricky to do. That one looks like almost little teeth coming around the iris there, and that's because it's little lines where they've separated out. So usually it's sort of a tight ring of fibrosis. You make little nicks and eventually it relaxes back, so you get a better view through it. Often it's more important actually for the examining person than it is for the patient. So if you've got someone with diabetic retinopathy, have tight anterior capsule phimosis, it's very difficult to examine the retina. So make that larger is a good idea. Epithelial ingrowth, just out of interest, rarely see that now, probably more with extracapsular rather than phaco. But you get these very interesting small cysts which tend to confuse everybody, which I haven't seen for some time now, but yeah. Good, so we'll move on to the quiz. There were some hands up and I can see some questions, is that right?
Couple of apologies. One person can't stay. We've lost only about 5 people. We've still got 81 here. We were up to a maximum of 88 in the middle. So there's a lot of people still here. Let's whiz through the quiz and get everyone to wake up before going on to their evening things.
Right. As I mentioned, a harder quiz this time. So question 1. Which of the following is a risk factor for complicated cataract surgery?
Is there just one answer, or can there be several?
Well, there's an option for all at the bottom.
Okay.
Jane, may we have the polls? You have to press the polls.
I'm gonna.
Oh, you're gonna do it. Okay. Good.
Okay, you do it.
That's on screen now. Good, it's got about 50 responses now. Final chance then. So I'll end the poll just there. It's got 61 responses. So hopefully that's on screen, is it?
I can see it. Can everyone else see it?
Good, yeah.
Yes, yes, yes.
Yeah, so so the answer is all of the above.
Yes.
So vitrectomy, or pupil dilation, older age.
One person has said they can't see it. I hope they can.
Can't see the poll. So the answer was definitely all of the above. Yeah, and I did try and catch you out. So I'll stop showing that now. So go on to question 2 then. If I change my slide, that'd be better. Good. So intraoperative floppy iris syndrome, IFIS, can lead to a small pupil, mobile iris during surgery, and an increased rate of complicated cataract surgery. What group of medicines commonly calls this? Got 16 responses so far.
It's rapidly going up.
It is.
I think they're getting it right. They were listening, watching.
Perhaps these. I think maybe I started off with easy questions. We'll get harder as they go on. Good. So I think that's pretty clear, isn't it? So it's the alpha blockers, tamsulosin, in patients with problems with their prostate. There are patients on doxycycline for their hypertension as well. I think that's a very minimal effect, actually. I think more comes from tamsulosin. So we'll end the poll there. That's very good. Question 3. Which presentation would be most likely to be acute postoperative endophthalmitis? Let's say a patient presents to your practice. It's 2 days after cataract surgery. The eye is white and their visual acuity is 6/60. 2 weeks afterwards, and they're complaining that actually their vision hasn't improved after cataract surgery. 1 day afterwards with red eye and anterior uveitis, or 3 days post with worsening pain and vision and hypopia. Good, so I think the majority are on that, aren't they? So we've got 50 odd responses there, so I'll end that there then. Good, so yeah, 3 days after cataract surgery, I mentioned, I think is the kind of peak incidence of acute bacterial postoperative endophthalmitis. Good, so, okay, here's a question for the presence of a hypopion always indicates postoperative endophthalmitis. Well, we're getting very quick responses this time. Good, so I'll stop at around the 60 mark, I think, yeah. Good, so it's a bit split actually, isn't it? So it's about 70%. So the answer is false. It doesn't always represent it. You can get hypopia from other causes. I think you'd have a high index of suspicion. Sometimes you can have other conditions that mimic it. You can get uveitis syndromes. So patients with HLA-B27 and uveitis related get hypopias as well. Also, with intense inflammation after surgery, you can rarely get a hypopia as well. So the trick question was always, so not always. Yeah. So the approximate risk of endophthalmitis following cataract surgery is 1 in 10, 1 in 1,000, 1 in 5,000, or 1 in 10,000. Good, I'll stop when we get to around 60 there, yeah. Good. So majority, well, 60% going for 1 in 1,000. So it's around about 1 in 1,000. I think it would depend on different units and different times when you check it. But overall, it's thought to be about a 0.1% chance of endophthalmitis afterwards. 1 in 5,000 is closer to, let's say, intravitreal injections. So probably say, let's say 1 in 2 or 3,000 of that. But with cataract surgery, around about 1 in 1,000. So stop sharing that. That's good. Perfect. So question 6 regarding positioning of the lens post-cataract surgery, which of the following is true? A, all malpositioned IOL should be explanted. B, the cataract surgery must have been complicated. C, previous trauma is a significant risk factor. Or D, the patient will always be symptomatic with blurred vision. So which of the following is true? Perfect. So we're coming up for around about 90% onto previous trauma being a significant risk factor. That's correct. Good. So question 7 regarding PCO, posterior capsular pacification, which of the following is not true? A, may involve Elfsting pearl, Summerings ring, or fibrous plaques. B, carries a significant risk of retinal detachment after a YAG. C, has a rate of formation of around 20 to 30%. Or D, treatment should ideally be performed 6 weeks after surgery. Good, so it's definitely a clear winner. My attempts to catch people out are sometimes working. So I'll end the poll there. So yes, so it's, I beg your pardon. Yeah, I've managed to catch everyone else. So I don't think there's a significant risk actually of retinal detachment after a YAG, a laser capsulotomy. So I think that although it has been reported and there's case reports of it, it has never been proven. So in large studies, it's not a significant factor. I think that some people argue that actually they've had their YAG laser capsulotomy and then weeks later got retinal detachment, but actually patients get retinal detachment after cataract surgery at any point really. So those two are not thought to be related. So I don't think it's wise to not perform a capsulotomy for the risk or worry of a retinal detachment. So yeah, I don't agree. So it's going to be, the answer is C, has a rate of formation post-cataract surgery between 20 and 30%. Good, so question 8. Yep. It's got buttons to click. A 40-year-old patient seen in practice presents with blurred vision distortion 6 weeks after cataract surgery. What's the most likely diagnosis? Is it A, macular degeneration, B, cystoid, C, posterior capsular opacity, or D, corneal edema? Good, so another harder question. Good, we're up to 60 there. I'll end that there. So correct. Answer B, cystoid macular edema. And you could argue that could be posterior capsular opacity as well, but I said the most likely. And it's the fact that it's distorted vision for me. So people with posterior capsular opacity often have glare, often have blurred vision, never really get distortion of vision. Distortion of vision is usually retinal. Well done. Perfect. Question 9. The risk of retinal detachment for a young patient with very high myopia, -15, after cataract surgery. Let's say they've had no posterior vitreous detachment. They're young. their risk of retinal detachment is A, 10 times higher, B, unchanged from the population, as if they hadn't had the cataract surgery, C, twice as high, or D, 4 times as high. So I got more mixed results today for this one. Good, definitely more difficulty as we're going on. Great, so we've got to stop at 60 again. Oh, stop at 59, okay. So it's about 10 times higher. So in the population, majority have gone for the 2 times higher, which is correct. So on average, not accounting for any differences, if you have a cataract surgery, you're probably about 2 or 3 times more likely to have retinal detachment. But if you are younger when you had your cataract surgery, perhaps, as I say, if you had a clear lens extraction, if you are, in your 30s or 40s before you have a posterior vitreous detachment, if you are very high myopia, minus 15, it's probably around a 10 times increase, tenfold increase in your risk. So something to be aware of for those patients to consider. I mean, to be honest, I think that cataract surgery needs to be done anyway. If you have a significant cataract, you need to have cataract surgery. But for those that are getting it done very early, or those that are having a clear lens extraction instead of having LASIK, or perhaps they're not suitable for LASIK, it does carry actually very significant risk. Good, and final question, then question 10. Which of the following are, let's get the question up, are not indications for vitrectomy post-cataract surgery?
So please note that it says not here.
Yes, exactly. Got some inspiration from exam questions. Trying to capture out. Yeah, so which of the following are not indications for vitrectomy post-cataract surgery? Oh, I can't see any results. Has something happened with the poll?
Everyone's still there. I'm not sure.
None of the bars are moving.
Yes. It is saying not started.
We can only see the question. We can only see the question. We can't see anything else.
Oh.
So you need to end. Yeah, and you need. Oh, it's gone now. You need to end the poll before the bars.
Oh.
It's gone. Go do question 10 again, please, if you can.
Yeah, I can't actually. Is there a box to
Well,
relaunch poll? Here we go.
Yeah,
Here we go.
yeah.
Relaunch.
Yeah.
Okay.
There we go.
There it is. Yeah.
That's better. Oh, right. So I've got stuck there. So yeah, which of the following are not indications? Good. Stop it there then. Seems to have reached a peak. So correct answer is D, posterior capsular opacity. Usually that's treated with a YAG laser capsulotomy. Again, rare cases if it's very severe, or if there's little fragments of the lens left behind, you could perform a vitrectomy, but in general not much more likely that you'd need one for nuclear fragments in the vitreous, dislocation into the vitreous of your intraocular lens, or postoperative endothermitis in the appropriate kind of vision range for the study. Good, so the answer is D. Great, so that brings the webinar to a conclusion. Thank you all for listening.